Once it crosses 100, you can start, Gopal.
Okay.
I'm muting myself.
Respected doctors, good afternoon. We welcome you all to this learning sessions on electrophysiology. I'm Gopal Chatterjee, Senior Manager at Tosco Medicals Private Limited and Product in charge of electrophysiology from Roland Consult, Germany. For 25 years of now, Roland Consult is a global leader in the field of ophthalmic electrophysiology. Today, we have esteemed speakers with us to share their information on dynamics of electrophysiology as well as their experiences using Roland system. Please put your all queries in the below question and answer box. We'll answer all your queries at the end of the session. Our first speaker is Dr. Praveen Sen. She needs no introductions. She is a senior consultant and head of electrophysiology department at Sankar Nethralaya, Chennai, with several years of experience in genetic disorders of retina. She has more than 90 publications to her credit and has contributed to several book chapters. She has made many presentations in national and international conferences. Today, she is going to cover on the basics of electrophysiology and its relevance on retinal diseases. Thank you, Dr. Sens, for being with us today. I hand over to you.
Um, so a very good afternoon to everyone, and a special thanks to Tosh Pro and Kiran for having organized this and giving me the opportunity to talk on a subject which I have spoken quite a few number of times, but to have it in the leisure of our homes and in comfortable surroundings where we are not pressed upon 8-minute talk and 10-minute talk is probably makes this very special, because sometimes it takes a little longer than 8 minutes or 10 minutes to really do justice to this kind of a topic. So to begin with the first topic, which is on retinogram, uh, can you all see my slides?
Yes.
Okay. So, what is so special about these electrophysiological tests? Why do we talk about them? Why are they discussed when we have such great imaging tools with us? So, the best part about this is that they are objective type tests and they don't need much cooperation from the patient. And though OCT has come in very recently, I'm taking the help of OCT to introduce ERG to you, and though ERG has been there for several years. So just like the OCT shows you the inner retina and the outer retina and all the layers of the retina, ERG can functionally dissect the retina just like OCT anatomically dissects the retina. So outer retina is nothing but the layer of the rods and cones or the photoreceptors which gives rise to the A wave, and the inner retina is nothing but the bipolar cells which give rise to the B wave, which is the origin of the B wave here. So just to quickly take you through the basics, though I'm not sure what exactly is the kind of audience, but I'm sure a lot of you are familiar with it. And I don't want to dwell too much of time on this and take you more towards the clinical side. And so the A wave is the negative or the downward wave, and it rises from the photoreceptors and reflects the photoreceptor function. And the B wave is a positive upward wave, and it rises from the bipolar cells and it reflects the bipolar function. Oscillatory potentials, just to see here, these are the wavelets which you see on the ascending limb of the B wave, are nothing but the oscillatory potentials. And this, the physiological basis, I have just kept one slide so that I do not put you to sleep. So the important thing to remember is that in dark, the inside of the cell is negative, about minus 40 millivolt. The gates, the cyclic GMP gates are open. There's a free movement of sodium and potassium. And when you have a stimulation or the light falls on these gates, the cyclic GMP mediated gates close. So the inward movement of the positive ions, that sodium and potassium, they move in because the intracellular space is negative. So that stops. Because that stops, the inside of the cell becomes more negative. So this is what is called the hyperpolarization, giving rise to the A wave. And this hyperpolarization is then followed by stimulation on to the bipolar cells. This happens by a release of a chemical at the junction between the photoreceptor and the bipolar cells, which further go on to depolarize the ganglion cells. And this is how the impulse is generated. So the need is that it is physiological abnormalities or functional abnormalities can actually happen much before the anatomical abnormalities, even something like the CST or the retinal thickness or the retinal abnormalities can be seen on OCT. So retina may look okay, but may not be functioning normal. So looks can be deceptive. So it is very important to look at the functional health of the retina. And this is the main outlay of how we are doing the ERG in the clinic. These details are very nicely given by the ISCV, which is the International Society for Clinical Electrophysiology. The reason they have given these standardized protocols is so that we talk in the same language, so that we know when we talk of A wave is low, we know that it has been stimulated at this stimulus with this background, because those are the parameters which can affect these waveforms very easily. So when we are going to interpret, remember largely four parameters are what we are looking at, which is the amplitude of the A wave, amplitude of the B wave, implicit time of the A wave, and implicit time of the B wave. Definition: time to peak is known as the implicit time of either A or the B wave, and the amplitude of the B wave includes the amplitude of the A wave because it is from the trough of the A wave to the peak of the B wave. So with this basics, let us see how we are using electrophysiology in the clinic. These are the some of the important diseases where ERG is used. I'll take you through to one by one. The most common scenario in a clinic is that the patient comes to you with a history of night blindness, and the first thing probably you may think of here is this: yes, I need to get electroretinogram done, an ERG done. So here on the first photograph on this side, this is a near normal looking fundus, and the ERG looks negative. So this, I don't think, needs any explanation. This is this kind of a typical picture in a young patient with near normal fundus and a negative waveform. You know you are dealing with congenital stationary night blindness. But if you have these typical features of bony spicules and extinguished ERG, it is RP. If you have this typical tapetal reflex, or and there is presence of a negative waveform, good photopic responses, it is Agushi. And if you have these white dots with the presence of slightly subnormal ERG, which improves on increased dark adaptation, it is fundus albipunctatus. So this is how, just with the clinical examination and ERG, the only single test, you can diagnose a case of night blindness. Now you have another scenario where you have a negative waveform, but here the fundus is not normal. You have foveal schisis here. So this has to be X-linked retinoschisis. Another patient, you have negative waveform and these hemorrhages, so you know it is CRVO, and sidrosis can also give you a negative waveform. The story of the white dots: you have white dots all over the fundus. You get an ERG done and it is normal, so it is benign fleck retina syndrome. But if you have these dots and then you have a subnormal ERG, it is fundus albipunctatus. But if you have a completely flat ERG with these white dots, it is retinitis punctata albicans. Not always you get all the answers. So these two fundus pictures look very similar with the presence of these white dots. ERG also does not tell you any story, but if you do an FFA done, you see these isolated areas of chorioretinal atrophy here, which is typical of Bete's crystalline dystrophy, and numerous flecks here, which is seen in fundus flavimaculatus. This is another scenario, cone rod dystrophy, almost near normal looking fundus again, but here ERG is almost extinguished. So this is a CRD. Again, we saw this, how OCT and negative ERG can help you diagnose X-linked retinoschisis, Stargardt's almost normal ERG, and uh, multifocal ERG, which is showing you an inverted crater appearance. A fundus flavimaculatus may be a similar spectrum to Stargardt's, but a more widespread disease. So you may have changes in the ERG. So here again, near normal looking fundus, but you see the photopic responses are selectively down while the scotopics are normal. So this is cone dystrophy. So these are the few examples which I wanted to share with you, but sometimes you need to be more careful in form of a rare diseases, and patient may come to you at an older age group, suddenly now complaining of night blindness. So in which case it may not necessarily be one of the inherited retinal dystrophies causing it, but it may even be something like a MAR or a CAR or a carcinoma-associated retinopathy, in which case patient comes to you with a sudden onset of photopsia. And if you do an ERG, in cases of a CAR, it may be absolutely extinguished. And in cases of MAR, you have the typical negative waveform that you see in cases of CSNB, because this is due to formation of antibody against on bipolar cell protein, which inhibits the bipolar cells, and the A waves are normal while the B waves get affected. So a clinical diagnosis is not only based on ERG, but the history, other investigations can also play a part. When we look at, we have to see the whole patient completely. And we must try to interpret whether it's the rods that are affected or the cones that are affected, or it is the bipolar cells which are affected. If you try to answer these questions one by one systematically, you will definitely reach a diagnosis. But then you may ask that in this era of molecular diagnosis, why do we need ERG? Why can't we just simply get in blood investigation done, and it can tell us what gene is responsible for this particular retinal dystrophy? The reason is that universal application is of molecular diagnosis is not possible in every case. And then there may be clinical heterogeneity of the disease. As you see here in this chart, it's a little confusing, but it's just to show you that inherited retinal diseases can be caused by more than 250 different genes as we know today. And we know only not more than 50% of the genes. So there may be more new genes still to come. So what is meant by genetic heterogeneity? That different mutations can cause the same disease. For example, RP is caused by more than 100 genes. So even if you do a genetic test, you may not always be able to get the answer. Phenotypic heterogeneity is like the CEP290. It can cause an isolated LCA, or it may give you a syndrome of LCA with kidney renal problems as well as neurological deficit. Clinical heterogeneity, when the PRPH2 gene in the same family may manifest as RP in one patient with teleform macular dystrophy in the other. So you still need to integrate it with your clinical diagnosis, especially when we know that inherited disorders, some of them can be caused by a single gene while the others by multiple genes. So I'll just show you how ERG can help us reach even the diagnosis of the gene in some particular scenario. So here you see there are some subtle yellowish spots that you can see in the periphery. Patient came to us with a decreased vision, and there is intraretinal schisis. And when we did the ERG for this patient, you see the scotopic bright flash looks almost identical to the photopic bright flash ERG. And this, when you see this kind of a picture, it means the cells which are firing in scotopic conditions are identical to the cells which are firing in the photopic conditions. And this happens only in one disease, which is the enhanced S-cone disease. And the enhanced S-cone disease is typified by the absence of L and M cones. As you know, there are three types of cones in the human retina. Largely the human retina has not more than 10% S cones. S cones behave more like rods. So their slow waveform is their large amplitude waveform. So this is all that you see in both photopic and scotopic responses. And this is typical of a mutation in NR2E3 gene. This is typical of enhanced S-cone disorder. This is another one. This fundus examination looks almost like a cone dystrophy. And you know the patient comes to you with photopsia and he has difficulty in the bright light. But when you do ERG, you would expect photopic responses to be down, which are down, but you will not expect the rod responses to be so huge, amplitudes to be so high as you see here. This combination of reduced photopic and very high or supernormal scotopic responses is known to be caused by only one gene, and that is the KCNV21. So the ERG is typical and very significant and points towards the underlying gene defect in these two conditions. In other conditions like this, the patient, an infant may come to you with a history of poor vision, not seeing. The parents may bring the child less than 1 year of age, and you see different type of fundus pictures, but all of them have an extinguished TRG. So these are nothing but various genes causing LCA. This is RDH12, this is RP65, and this is the crumbs protein. So information and knowledge of these things is very important. Here again, night blindness and extinguished TRG, you would expect the patient to have peripheral pigment, bony spicules, but instead he has a large punched out scar in the fovea and very few pigment. But this still is RP because the rod and cone photoreceptors are down. And this is nothing but circle mutation causing retinitis pigmentosa. And this is another typical feature of circle mutation with peripheral scalloped lesions in the periphery. Another patient, night blindness, but very few pigment and near normal looking fundus, and you would think, is the patient malingering? No, the ERG tells you that it's a flat ERG, and when you do the genetic testing, it is the EYS gene. So you have to understand the various manifestations. So many difficult atypical genes can have the same disease or the RP. So the knowledge of ERG, getting a functional testing of the retina is very important, even if the retina looks normal. Especially genotype phenotype correlation is important in this era where gene therapy is available and the patients may come to you questioning what can be done. I'll quickly take you over to this specific entity of congenital stationary night blindness, because here the ERG plays a large role in, again, understanding the disease process as well as understanding the underlying defect which can be there. So there are two types which we express, which is the RIGS and the SB type of CSNB. In the RIGS type, you have the rod receptor, which are more commonly affected, rod photoreceptors. So the A wave is affected. But in the SB type, you have here, you can see that the incomplete and the complete CSNB, the complete CSNB, which affects only the on bipolar pathway, so that you have normal A waves, but you have no B wave. And because it is only the on bipolar pathway which is involved, it is only the scotopic ERGs which are affected, whereas the photopic ERGs, they remain the same. So a gene which is affecting the on bipolar cells is going to give you a negative waveform only in the scotopic pathway, while the photopic uh, responses remain unaffected. RIGS type, because the defect is in the rod photoreceptors, so you have A wave is also decreased and B wave is reduced, because once the A wave is affected, B wave automatically becomes down. And since the photopic pathways are generally normal, the photopic waves are good. In the incomplete CSNB, you have on and off bipolar pathways, both are involved. So the rod system also gets affected and the cone system also gets affected. So you have negative waveform as well as reduced photopic responses. So this is how you can differentiate between three different types of CSNB. Importance being that the RIGS type sometimes can slowly progress while these two remain unaffected. Incomplete CSNB, because it is affecting the cones as well, sometimes the patient may come to you with photopsia or history of photophobia, and that may mislead you. So this it is important to understand this entity. Normal looking fundus, negative waveform, slightly reduced photopic responses can be incomplete CSNB and not necessarily cone dystrophy. And the importance is this is non-progressive, while cone dystrophy is going to be progressive. So this is what I had just discussed, that the incomplete affects both the on and off pathway, and this is usually caused by the CACNA1F, and complete CSNB is usually caused by N by X. The RIGS form is caused by the SLC24A1 gene defect. So this is how this looks different. If you see, this is complete CSNB, the typical features of tilted disc, staphyloma because of myopia, tessellated fundus. This fundus really looks normal. This is the feature of complete ERG, near normal photopic responses, vis-a-vis this, because the rod responses are also gone, because this is the RIGS type, which is caused by SLC24A1. The photopic responses are also down to some extent, and you see the difference is that this one is caused by TRPM1 gene defect, and this is caused by SLC24A1. So the ERG along with the fundus examination, these two things only we have done, and we can reach this diagnosis as to which possible underlying gene defect could cause it. Not only in the inherited disorders, but in the electrophysiology can also give you information in diabetic retinopathy. In fact, the blood vessels form not more than 10% of the retina. 90% of the retina is formed by the neural tissue. So it is naive to think that the diabetic retinopathy is involving only 10% of the retina and leaving 90% of the retina unaffected. In fact, the ganglion cells are more affected by the high blood glucose levels. Another newer entity is the photonegative response, which is more affected, typical, and it is more sensitive to pick up diabetic retinopathy. I'm quickly going through this because we have very little time. And EOG, to just, this is the method in which you do it. And the important thing is for EOG is in bestorinopathies or the BEST1 mutations. So it helps to differentiate between the four types of presentations that BEST1 mutations can give you. So if you look at vitelliform macular dystrophy, this is something which we are used to seeing. So in this, typically the EOG is down, the ERG is normal. In autosomal recessive bestorinopathy, it's a widespread spectrum. So EOG is also down, ERG is also down. Adult vitelliform macular dystrophy, both EOG and ERG are normal. In Adwaric, this is a rare entity which has extensive rod and cone dysfunction as well. So there is severe affection of both EOG and ERG. So this is just one example of a well-defined lesion. This is VMD. This most of you would have seen. This is autosomal recessive bestorinopathies typified by these yellowish spots which are there in the mid-periphery. And then when you do an ERG, you see subnormal responses, slightly subnormal, but EOG is 1.1, which is markedly less. Anything less than 1.5 is definitely abnormal. And this is adult onset vitelliform where ERG and EOGs are both normal. So application is everywhere and an integrated approach is what is required. ERG along with other tests, you put them all together in the clinic to reach a diagnosis. And this is my team here who helps me make these diagnoses, the genetics department, my VR team, and the electrophysiology team. So with this, I've mixed the ERG and EOG together. So I don't know if you would want me to finish the next topic as well before we take the questions, or shall we take a break here?
No, ma'am, you can finish the next topic. And questions we can take at the end of the sessions.
All right.
Thank you.
So, so coming next to multifocal ERG, my slides are visible. Yeah.
Yes, ma'am.
Okay, so multifocal ERG is something which has been devised to tell us about the focal retinal responses, because ERG, if you see, is a full field response. It gives you a global affection of the retina, but the maculopathies which affect only the macula, they will be missed on a full field ERG. 50% of the retina has to be affected before it affects the full field ERG. So for that, multifocal ERG is there. So both rod and cone function can be seen on full field ERG, but remember, multifocal ERG in contrast is cone driven. Why? Not because it is the macula it is testing, but because it is tested under photopic conditions, under light adaptation. So which is why it is measuring only the cone responses which are in the central 40 to 50 degree, because the stimulus that is used is falling on the retina only in the central 40 to 50 degree. Usually the Burin-Allen contact lens electrode is required because we need a good stable configuration, and the BA gives you the best stable configuration possible. Fixation is of the utmost importance in multifocal ERG. If patient is not maintaining fixation, you can just leave it, give up. It is not worth it to look at that ERG report, multifocal ERG report also. So things like refractive errors and rim effect can affect the multifocal ERG because it is vision dependent. So if the vision is less than 660, again, multifocal ERG is futile. This is the typical stimulus which is given to the patient. So it is either in form of a 37, you could have only 37 hexagons stimulating, or you could have 61 or 103 or up to 241. The disadvantage and advantage being that 61, you could probably do it quickly and give you a quick result, but the very large ones could take a very long period of time, and the patient may not be very cooperative to do this. So usually an intermediate of 103 elements or so is the best bet to do it. And importance, it tells you not only the it is not like a focal ERG, it is multifocal. So it gives you the distribution rather than the how one part is affected. So here it shows how it can show you whether it's the fovea or the perifovea or the parafoveal area which is affected, because you could see. And then this is the topographical map which gives you an overall view. But when you are analyzing, this is not the best of the way to analyze, because you may lose the real character of each waveform. So a trace array which gives you the each waveform is the one which is most important. So the components here, it almost looks like the full field ERG, and the component origin is almost similar, but it's not completely similar. This is the first negative waveform, which is almost like the A wave, and this is the P1, which is almost like the B wave. So here again, the parameters are the latency of the N1 and P1 and the height or the amplitude. So as I said, it is almost like the A wave, but not really the A wave, because here I'll spend a minute on this slide. So if you look at this, this is the white hexagon which has been presented on this particular focus of retina. And this white has also been, stimulus has been presented at this focus of retina. The reflex, the response you would get will depend upon whether the previous one was black or white. So the first order kernel gives you the sum of all the white presentations, irrespective of whether the previous of was black or white, and subtract it from all the black presentations, irrespective of whether it was black or white before it. So it is a mathematical extraction. You need not worry, break your head on it, but it's just to tell you that these are not true waveforms. These are mathematical extractions from the particular point or the focus of retina, because the response will depend not only on the whether the white hexagon has been given or the black hexagon has been given, but will also depend on whether the hexagon stimulating before that was black or white. So a lot of temporal summation happens, and the response, luckily the machine does it all for you, and you don't have to worry about the first or the second order calculations. So this is how, which I mentioned, that this is how you compare it, and you have to have your own reference data as well. Some defects which you commonly see, you can see that the central area is down here. So this is the central retina which is affected, vis-a-vis the central retina is good here, and the peripheral dysfunction most likely RP. And here you can see generalized reduction, and here you can see it is the inferior part which is more affected than the superior part. So it gives you the topography of the effect. Some artifacts, very important to remember these artifacts, because multifocal ERG can be wrought with them and your interpretation can go absolutely haywire. This is a good waveform, a good report. This is electrical noise which is present everywhere. This is eccentric fixation. Patient is not seeing at the center, but patient is seeing here. So all good waveforms are here and all bad waveforms, smaller waves are here. These are some rim effects where this area has been blocked, but this area is still looking good. So some clinical applications, again, we uh, will quickly go to what we call the most important one, and which is drug toxicity in multifocal ERG, and most important being the hydroxychloroquine toxicity. Most of the time people have questions regarding this, so I will spend some time here. So here you can see it, hydroxychloroquine does not affect the rest of the retina. So you are not going to get any information out of full field ERG. Only information that you get on the surface through it to rule out that there is no global affection of the retina. And the central area is affected, so the beautifully multifocal picks up that the central area is affected. Chloroquine can cause toxicity at half the dose of hydroxychloroquine, and this is a very nice article by Murmur et al. And AO recommendations as to what test should be done at what time, and multifocal ERG and FAF form an integral part, though they have given the primary importance to SDOCT, but they have explained that the SDOCT is more important to do because, fortunately or unfortunately, OCT is more available with everyone and multifocal ERG may not be available. So, and these are the indications that as long as your dose is less than 5 milligram per kg body weight, usually the toxicity is less. And at base, after you have done a baseline screening, and if your doses are less than 5 milligram per kg body weight, you can actually begin screening, annual screening only after 5 years. These are few other drugs which we did come across causing toxicity, and we have published them as well. They were very nicely picked up because of multifocal ERG. Full field ERG would have missed. So just like diabetic retinopathy can affect the full field ERG, it can affect the multifocal ERG also, especially where edema is concerned. The DME affects the latency of these waveforms. And here you can see that this is a diabetic patient without diabetic retinopathy, and look at what it has done to the ERG is already is haywire, and here ERG is like a squiggle, and this is not even early diabetic retinopathy. So very early on in the stages of diabetic retinopathy, we have recently worked on this also, that even in patients who have no obvious DR, the multifocal ERG and PHNR are completely more than 60 to 70% subnormal. So other vascular disorders as well can be easily mapped by multifocal ERG. So things to remember, or the caveats, is that always do a full field ERG first to make sure as to you are not looking at a global affection, and then you do a multifocal ERG. Don't try to interpret multifocal ERG in isolation. I must talk about pattern ERG, though that was not really one of the topics, but it helps us differentiate between the maculopathies and the optic nerve disorders, which is sometimes one of the most common question which comes to you in the clinic, and then you have to do an ARG to see which is what. It is done with the detailed electrodes because the response is so small that if you do through a bilateral electrode, that the contrast, the focus will not be so great. So this is detailed electrode which is required here. And these are the components, two most important components, the P50, which is dependent on the luminance, which means it is shows you the macular function, the N95, which is contrast dependent, and it shows you the optic nerve function. So this is one test which slices and differentiates nicely between macular dysfunction. So if your vision is lost or decreased because of a macular function, you'll have loss of P50. But if your vision is decreased because of an optic nerve problem, you will have loss of N95. And this can be a very, very useful tool in the clinic. So we'll see some examples. You can see here that the P50 is subnormal, ERG is normal, which means it is a maculopathy. P50 is subnormal, ERG also subnormal, means it's a pan-retinal disorder. But here you see, this is your P50, nice peak is there, N95, good peak is there in the right eye. P50 is down, and here also the N95 is down to some extent. So what is it? So is it this is this is the pattern VP. So you see the amplitudes are reduced almost to half. So if your pattern VP amplitudes are reduced, so how do you interpret it? Is it an optic nerve dysfunction which has caused it? No, a simple diabetic macular edema can do this to pattern VP. So until and unless you do a pattern ERG along with the pattern VP, you will not know whether you are looking at optic nerve dysfunction or a macular dysfunction which is causing a drop in pattern VP. So these are the differences that if you have an optic nerve dysfunction, usually the only thing which is affected is N95 vis-a-vis a macular disease which can reduce the P50 and N95 both. And the important is that the N95-P50 ratio is decreased in optic nerve dysfunction, whereas the N95-P50 ratio is normal in macular dysfunction, even though N95 and P50 both may be down. Most important implication of this is an optic neuritis. So first 3 weeks, patient of optic neuritis comes to you with a sudden drop in vision. When their vision is less than 660, 360, your pattern VEP and PERG both are going to be unrecordable, something like this, as you see here. But after 2 to 3 weeks, as it starts picking up, you see that the pattern VEP latencies are increased. The N95 component does not increase. The P50 component comes back to normal. This is pathognomic of optic neuritis. So this is how you are differentiating optic neuritis with the help of, if this is an example again, you can see N95 is missing here, the N95 is good. So this is a unilateral loss of vision due to optic neuritis. In Leber's hereditary optic neuropathy, where the loss of ganglion cells can happen right in the beginning, you may have N95 component which is down right at presentation. So this is an example of that. So this is how you correlate with various tests to reach a diagnosis and various components. So I just touched upon all these electrophysiological tests, but they can be extremely useful. And it is not only about retinitis pigmentosa and Stargardt disease. With that, I end my presentation and we can take questions, or we could go to the next speaker, whatever you decide.
Yeah, madam, we will go to the next speaker and questions we can take at the end of the sessions.
Right.
So thank you, Dr. Sen, for your excellent presentations. We are sure this will definitely help our viewers to understand electrophysiology a little better now. Thank you so much.
I really hope so.
Dear doctor, I take great pleasure in introducing our next speaker, Dr. Muhammad Farooq Musa. He is a director of ophthalmic imaging and diagnostic unit at Hamad Medical Corporations, Qatar. He has done his fellowship in investigative ophthalmology and ophthalmology clinical research from USA and PhD in ophthalmic science. His main interest is in electrophysiology of vision. He has more than 27 years experience in ophthalmic imaging and diagnostics. He is also part of many academic organizations globally. Today, he is going to cover one of the challenging topics, Electrophysiology in Pediatric Ophthalmology. Thank you, Dr. Farooq, for being with us. I hand over to you.
Okay, thank you so much. How many minutes I have?
You have 20 minutes.
15 minutes. Good. How's my voice, guys? You can,
Yes, yes, it's okay.
because I'm outdoor. First of all, good afternoon, everybody. And I'm outdoor and there's a lot of noise. So I hope that my voice will be okay. Is any noise in the background or something?
No, it's fine, doctor.
All right, good. Perfect. Okay. Good afternoon, everybody. It's my pleasure to be back in India virtually. Uh, although I like being in India, I've been many times in India and I really appreciate the culture and the people, very warm people and hospitality. A lot of experiences also in India, especially in ophthalmology. Um, Today, my topic will be very precise. I understand that ophthalmologists usually they hate electrophysiology for many reasons. Number one is because they always feel it's complicated, there's too much information, and they cannot interpret all that. And from another reason is they feel like they don't need it. They feel like the electrophysiology is a kind of a luxury test that won't add anything to us. Um, so today, I just want you to focus with me on a very simple approach. I don't want you to, I'm not here to make you memorize so many clinical patterns or in details. If there's any one message for you to take home today is that we reach an agreement. For you as clinicians, I want you to agree with me that you need electrophysiology test in your clinic. Whether you will be the one to do it yourself, by yourself, or you will request the test to be done for your patient elsewhere. So if we agree that it's needed and you are interested in depth to perform the test yourself and you have your own lab and your own technical staff, then this is another level which require you to have some kind of knowledge or a certain level of training. However, if you're not interested to become a part of this community, but again, you agree with me that we need the electrophysiology test for your patients, then you can simply request the test to be done in order to utilize the information that the test will provide you. So I just want you to relax for the next 15, 20 minutes. We'll talk some simple terms. For me, try to show you the evidence that electrophysiology is essential for your patients. I'll specifically try to focus my talk about children. And we all know that for those ophthalmologists, pediatric ophthalmologists or other specialties that they handle young patients and children, you can always expect some obstacles. And these obstacles related very much to the child himself, because you lack meaningful communication. You can't just ask the child, what do you see, or what kind of a complaint he has. You always have a problem in this level of communication. The second thing is in examination, especially in hereditary disease, the majority of the time, the information you get from the examination is not adequate or not informative enough, or in some instances, it look alike. And also since you cannot communicate directly with the child, then you'll get the majority of your knowledge and histories from the parents, and the parents sometimes are not very helpful. They cannot give you a complete picture. You really need the parents to be educated or have certain skill of observation about their children. When did that start? How the course of or the progression of the disease? And in these situations, it's a matter of luck. You can get parents who are not helpful in reaching the diagnosis, and sometimes you can get very meticulous and careful parents. Overall, electrophysiology testing is a blessing. And the reason we always say that is because In the middle of all that, while you're dealing with children in a confusing presentation, you are being offered valuable objective information. When we say objective, ophthalmologists always appreciate the word objective versus subjective. We have so many things that is subjective information in our daily examination. One of them, which is the most common thing, is the visual acuity. Visual acuity is a subjective test. Basically, you ask the patient to tell you what he sees. So it's not solid. It's not something you can build on. Many times it's not accurate. So electrophysiology is precisely bypass this problem and offer you information without the input of the patient himself. It's practical and feasible in the sense that you can allocate small space for you to conduct the service. You can train minimal number of technicians to conduct the service. The number of patients you will require to perform the test are easily organized. And when we say it's an objective test, we here want to focus on two main things. Number one is that electrophysiology in general can discriminate confusing presentation, meaning that it can give you information about certain confusing presentations that can tell you, no, don't go for that direction, stop here, you need to go for that direction. Also, it can localize the defect level, as was mentioned before, that our, as all of you, because I assume that all of you are ophthalmologists, know that the visual pathway is a multi-layer pathway, that each layer is transmitting the signal to the following one. So basically, you can have a hold or a block at certain level, and clinical pictures sometimes do not give you that very easily. So this is one of the functions of the electrophysiology, can localize the defect. In addition, you can follow up using your baseline examination and build your prognosis and follow-up examination based on this, this initial data. So when should we do it? Is there any perfect age in children? No, there is no perfect age. Basically, in our lab, for example, we perform that from day one. As long as you know what you're looking for, and as long as you know what to expect, those are two most important things. For example, you're not going to see the clear, crisp waveforms or responses that you get in an adult. So if you do a lot of children, so you should know what you expect. So the age is not really a big matter. Is there a perfect child? Of course not. There's no perfect child. All children will give you the worst nightmare of a test. So you have to develop the skill of how to manage the child during the exam in order to obtain meaningful data. Now, there are perfect testing procedures though. That's why when we say you have to look for which equipment you recruit and to buy and invest the money, this is very essential, because you need equipment that it would be trustworthy. Also, we have the perfect preparation, meaning that each patient and each child need to be prepared very well in order to get him into the test and get the results accurately. Without this preparation, you might get some problems. Also, you need to understand that there are so many testing protocols available. Each protocol specifically focus on a certain part of the visual pathway or certain pattern of how the vision is being tested in this level. So when you want to test or evaluate a certain problem, then you need to know which protocol is needed in order to attack this one. The overall golden rule is that you need to do as many as possible. This is what we need to do for children, as many as possible, because every single bit of the electrophysiology testing is essential. Don't try to be like, I will do only one test, because one test will give you one aspect, one piece of information, one piece of the puzzle. Then you won't do anything with this. Just a quick word about the maturation. We have here 5 different age groups, up to 3 months old, from 3 to 6, 6 to 12. Then all of a sudden it jumps to 1 to 3 years and 3 to 15. The development here in the visual pathway is not necessarily related of what the child see, as much as related to how the visual system evolves during this age groups. In other words, there are compensations happen in the visual system that can give an overall picture or image that the child able to see. But the specifics, maybe it will take time in order to fully mature over the age group. For example, the latency, which indicates how fast the signal is processed. In a younger age group, like 3 months, of course, it's delayed. And that's why I told you in the previous slide that when you perform the test in the young age group, you should know exactly what to expect. Don't expect that you will go for something like this, which is the 15 years old, because if you're expecting that and you get the delayed response, then you will say, oh, there's something wrong here. And then you'll assume that this child has a problem while he doesn't have a problem. Also, the amplitude of the signals is also different. It's much smaller, which is the same for everything else in children, compared to the regular adult age group, like 15 years old. Oscillatory potentials means simply that the signals, the intraretinal signal transmission is being developed. That how much the retina is becoming more sophisticated and complicated in how it manages the signal between the layers horizontally and between the layers also vertically. So now you can see that in the young age group, it's not very well developed, but also when you get in the older age, it's more well developed. The ratio of the AB wave, which is the transmission of the signal from the outer layers, photoreceptors, toward the inner layer, is almost constant, meaning that the AB ratio is constant between the young age group and the old age group. Now, also a quick word about the photoreceptors. We all know that we have, let's say, 4 different kind of photoreceptors. We have the rods, which is a different pathway, and it's concerned mainly with the dark or night vision. Then we have 3 different kinds of cones. It's classified according to which light wavelength it would be able to capture. So we have short, medium, and long wavelength. Overall, the short wavelength in the young age group till 3 months old is overlapped between the rods and the S cones. And this is the first to develop, and during the early days, this is more mature than the rest of the L and M. However, the M cones start to kick in by 6 months, and then by 9 months, you have fully functional cone system. Now, in order to approach a diagnosis for a child, you need to do vision assessment if possible. And when I say vision assessment, this is something among ophthalmologists, it's a common mispractice, and even in the reports is misreporting. Visual assessment doesn't necessarily mean visual acuity, because there are other things related to the quality of vision. And the quality of vision related to contrast, related to night and day vision. The only thing here that you need to learn or to know how to ask about these things. For example, the night vision problem. Many times we see patients, the doctors, they will ask the parents very direct question: does the child have a problem at night? And the mom can simply answer no. But if you ask in a different way, like asking about when does he hit anything while he goes to his bed? Some people report that yes, he can bump into the bed, cannot go to bed clearly, maybe because he had to switch off the light. And when he switch off the light, by the time he get to bed, he can bump into things, stuff like that. But I really encourage every ophthalmologist to go very meticulous about the history, especially with children. Also, the type of visual loss that is complained, like for example, as early as the 40 days, the first complaint that we usually hear is the mom will come to the doctor asking him, saying that the child doesn't follow me, doesn't look at me. And that means that he cannot fixate centrally. It's very difficult to do an assessment before 1 year old for the peripheral vision. However, you can do that, but it will not be accurate, and it will not give you more information about the whole system of the vision in this child. Now, as we said, clinical examination is as essential. Sometimes you don't get much information, but this is also important to understand that you need electrophysiology to kick in and give you more objective information. Now, just simply, we can follow a very simple algorithm about the vision in children. The vision will be either not assist, you're unable to assist the vision in the child due to any reason, or you will be able to assist the vision, and then you will realize that you have either a normal vision or a poor vision. Now, regardless of the situation that you're having now, whether there's assessment of the vision or there's a normal vision or poor vision, you have a visual complaint. That child came to your clinic for a visual complaint. So you might have some ocular changes or a complaint that you would be able to identify. Maybe you will have a positive family history. Maybe you can even have a systemic association that can give you the diagnosis. However, electrophysiology testing is very essential in all three situations. Whether you were able to assist the vision, but you still have a complaint, or you're unable to assist the vision and still you have a complaint, in the three situations, you will be helped by the electrophysiology testing, either in the diagnosis or the level of visual assessment. Because when we manage children, we have very limited questions. And this is important for you to understand, that we are not in the position to have a full scope or a full itinerary about the entire visual pathway at that age. You need to know a simple question, whether there's vision or no vision. And if there's vision, am I able to do assessment or not? And if I'm able to do assessment, then which level and quality that I have in this visual assessment. Now, on the other hand, if there's no vision, then I need to know this no vision coming from which level. Is it a retinal problem or post-retinal problem? And if it's post-retinal problem, which level of the post-retinal pathway that is affected? And if it's retinal, which part of the retina is affected? Now, I think I'm going over my time. I'll try to speed up a little bit. This part was explained earlier. I don't need to spend time on that. Now, testing preparation. I want you just to have a quick point. Feeling that the electrophysiology is difficult to do doesn't mean that you don't need it. And this is something important for you to understand. Learning how to handle the child is easy. You just need to know it. You need to learn it. In our lab, for example, we train technicians, we train ophthalmologists on how to manage the child. In other words, if you will be able to train your technical staff on how to handle the child, you will get the most accurate responses that will help you in the clinical diagnosis. Now, calibration and following testing guidelines and the protocols, this is also very essential, and you have to follow. We strongly recommend to create the normal values. When you use your system in your own setup, in your own office, in your own country, you need to create your own normal values, because electrophysiology testing cannot be that much standardized, but there's always a normal variation among people, ethnic backgrounds, races, even the setup, electricity in your home city, your home office can also um, interfere. Now, sedation and anesthesia option, um, in my experience, I rarely anesthetize the child. I don't use any anesthesia. Sedation we can do in about 10% of the children when we really need it, like cerebral palsy children, a really uncooperative child. Now, for the dark adaptation, we all know that children have this darkness fear so we try to minimize the time required for dark adaptation down to maybe 5 minutes. And you can get by with that and get very good results. Now, electrodes. Skin electrodes, from my own experience, is very sufficient, give you very good results. You don't need to do anything extra. It's not as sharp and crisp waveforms as you can expect in the corneal electrodes, but it can do the job. Now, there are many studies done about what would be the most important factor that you need to avoid in order to get accurate results. The most important thing is not to let the baby move the eye. Eye movement away from the stimulus or the source can reduce the response. However, if the child up to 6 months old closing the eyelids, you still can manage and get good waveforms. Now, we want to judge more or less an overall judgment for children, not specific figures and numbers. For example, we need to know to monitor for the existence of the waveform and its own components, the shape, the timing, the amplitude if possible. Why I'm saying this? Because children don't usually represented by very clear and easily identified waveforms. Now, these are the available elective ERG protocols, which done mainly by using the corneal electrodes. When we say ERG, meaning that we are only focusing on the retina and retinal layers responses. Now, these could be done by flash stimulus or it could be done by pattern stimulus. And in overall, I want you to take home one rule. Whenever we have a flash stimulus, that means that we want to get a response from the entire retina. And if we want only to focus or challenge the macula, we are using the pattern testing. As I said, when we are examining children, we never do one test. You never do a single test and say, I have an answer. You have a piece of an answer. Now, we don't want to go in details about the specific kind of testing. I just want you to understand a little bit about what kind of abnormality that we can get. This is, for example, the scotopic rod specific response. This is a simple positive waveform that comes in response to rod's activity in a dark adapted child. What you can get is something like that, or something like this, or like that. The first waveform, I can call it extinguished. It's completely flat. That means that there's no response. The second one is a mild, a response exists. And the third one is a subnormal. Now, for some people, this all squiggly lines that it doesn't mean anything. But at the end, as I said, if I can tell you that you can do one test and it can give you an answer and quantify the response of a single cell in the retina in a patient have a visual complaint, and this quantification can be easily represented for you between completely extinguished or mildly existed or subnormal. I think this is a good deal. This is something can offer you information about the action of these specific cells. This is the classic waveform that we see everywhere. It's called the maximal combined response. Again, this is completely extinguished. This is the waveform without the first part, which is the A wave. And this is the third waveform without the second part, which is the B wave. This is very informative waveform, and it's objective. It has nothing to do with the patient response. In the first one, it tells you that the outer retina, which is the photoreceptors, and the bipolars, they both have a problem, or one aspect of this problem is affecting the other. The second part, it tells you that the photoreceptors is the problem. And the third waveform, it tells you that the bipolar, the catcher of the signal, is the problem. It's the same thing in the pattern ERG, which also has two main components, and either the two components are gone, or you have one component is missing, or the other one is missing. Now, I just want you to understand that this is an overall assessment for you to understand that when I do this test, I will get solid information about specific layers of the retina. And this is very essential because now currently we can do OCT, for example, and get structural analysis of the retina. But sometimes the structure of the retina is intact and healthy. You don't know anything about the function of these cells. So when you combine the structure analysis in addition to the function analysis, then you have a full image and a full picture. This is the classic waveform of the pattern VEP. This is the classic waveform, the standard waveform of the flash VEP. And this is the normal variation among adults in normal population. This is how it looks like in children. It looks like something like that with high signal to noise ratio. And this is what I'm telling you. Do not expect anything near the adult or the clear, crisp waveform. You have to learn, I mean, not you specifically, but whoever interested in this kind of field, they need to know that what they get in children is different from what they get in adults. Now, these are the common presentations, and we are not in a time now to be able to go in details. I just want to jump to the conclusion that children in general, they will require you to do the proper assessment, to do the history, the clinical, and everything. In addition to that, you will put yourself in an initial diagnosis category. Then you can expect some errors or some problems that can exist in response to this problem. Now, when you add the electrophysiology testing, this will give you a different scope, a different vision, a microscopy examination of the retinal layers itself without the input of the child. Now, when you want to plan this testing strategy, you have to attack where the problem that you can expect. Again, one of the most important things is that you have to have a trained, skilled technicians who are performing the test, or if you do it yourself, you need to have a good training before starting to have the service. Now, just a last word for you to say, as I said, my purpose is not to make everybody listening now to be expert in electrophysiology. This will never happen. We all have our fields. But my important thing to message to you is that when you feel like you need electrophysiology in the assessment of your patient, then you will seek it, you will require it, you will have the input, whether you would be able to allocate time to learn the skill, or you will seek it from elsewhere who are more advanced in this kind of experience. And finally, thank you very much for this opportunity. And I'm really thrilled to be with all of you today. Thank you so much.
Thank you, Dr. Farooq, for sharing your experience and valuable inputs handling the child cases. Thank you, sir.
Yeah.
Our next speaker is Mr. Joachim Fingers. He is the founder and the head of Roland Consult, Germany. Roland is a market leader in the field of ophthalmic electrophysiology for last 25 years. He's going to share with us some of the latest development on Roland products. I hand over to you, Mr. Finger. You need to unmute yourself. Yeah.
Hello
Yes,
and
we can hear you.
good afternoon. Can you see the screen?
Yes, yes.
Oh, perfect. So I will talk something about our company, Roland Consult, and maybe many of you know already our company, and we started in the year 1993. And the name comes from the Roland. This is a statue in our city, and this is a symbol for protection and strength. And consult means we want to help our customers to get good results with expert training and sales and support. And I talk now from our office, and this I think is fantastic technology that I can sit here in the city Brandenburg and been connected to many places in India. Welcome. So next. So we work with international distributors. We have over 25 factory trained distributors worldwide. And we make for the training every year a course in the city, Brandenburg or Berlin, or we make special trainings in our office, and also customer support like this over the internet. And you can see here's a picture from last year. This year was a special situation, was cancelled, but we hope next year is possible to have our annual course, and the information you can see on our website. So I will talk about a little bit our system. The system is Retiport Scan 21. This is now the third generation in the developing and has what we need, all ISAF standards and more. You can see all the protocols. You listen about all the tests, and we can do with our system all the special diagnostic tests to test the retina or the complete visual pathway, including the visual cortex. How to do is explained also in the ISAF standards. So our system is modular, and we can make our device according to customer requirements, according your requirements. And for this, we have different models. It started from the basic, and the Gamma Plus Square is the most advanced system with all the different protocols. You can see here. So, and the delivery, you heard, is necessary that you have normal values. We deliver the system with normal values, but each lab can easily change these normal values after you have your own normal values. And it's also our standard to have also different age groups. And here you can see an example. You have here a scotopic ERG, and here you see the range for the B wave in the time. And here you can see the amplitude. So here you can see the typical multifocal ERG, a ring analyze. You know from the multifocal you have from the different areas the responses, and you can see the green is from the central and the different rings. And here you have also the normal values and the real values in the amplitude and in the time. With the normal values, we have also a new possibility to show a typical curve in your analyze screen or in the print screen. Then you have here the results from the right and left eye, and you can here have also a typical curve. And this is easy. You can select this typical curve from your responses. From your database, you can select one patient as a typical patient, and then you have this additional information, how should look my typical waveform for the different results. And this you can have for pattern VP, pattern ERG, for all the steps in the ISAP ERG. So then we have the modern LED flashes stimulator. One is Gansfeld. This is for the clinical routine. SC means super color. We have all the different colors, 5 different colors. Then we have the baby flash. This is for screening, is a screening device. And then you have a mini Gansfeld. This is precisely ERG. When you work with children, then it's not necessary to put the child in front of the big Gansfeld. Wait, screen. Hello?
Yes, Mr. Finje.
This, also, okay. With the screen, we have also, we deliver also with the stimulator, we deliver also calibration tools. The LEDs are stable for a long time, but it is also necessary to check the intensities of your stimulators every year or every 2 years to be sure that the intensities are correct. If you see some changes in the values, the changes come not from the not calibrated system. And the calibration check is based on the light meter Marvo monitor. And this can be done by all trained distributors, but also if a clinic want to do this by themselves, we can also train the clinical engineers to do the calibration in your hospital. The other advantage is you have to work in the dark room for the scotopic ERGs. And you can use the red light in the dark room to put electrodes, but you can use the dimmed red light from our Gansfeld also to check the placement of the electrodes. And other advantage is you can shut the PC monitor. The background can be set in red-black mode for scotopic test. That the screen light will not distribute the darkness for the patient for the scotopic tests. Also, we can measure with the camera, we monitoring the patient, but also very nice is we measure the pupil size also automatically. And to know the pupil size is also important for comparison with the standard values. The standard values was made with dilated pupils, but the dilated pupil can be 7 millimeter or 9 millimeter. And if the patient has a very small dilated pupil, then we expect also lower values because the value from the responses depends on the light. And so it's additional, very good additional information that you know exactly the pupil size. So then we have for when you work with children, it's necessary that the people look all time to the center of the screen for the VP. And we have cartoons, and this cartoon change during the test and then attract more the child to follow the checkerboards. And in the talk was also, in the previous talks was also discussed that you never have one signal in one test for children, especially, or if the signal is on the border, then it's recommended that you make 2 tests, 2 steps with the same conditions. But with our new function, even and odd responses, this comes automatically. This is easy and convenient to check the reproducibility of the responses. If it's not necessary to have 2 steps, we automatically separate 1 step in the even and odd responses, and very fast you see the reproducibility. The next test is the objective visual acuity, or the next possibility with our system. And this is very nice. Then you can check the visual acuity objective. And our software is based on the paper from Professor Ritter. We use the VEP, and we use different cycle per degree stimulation, and this changed here, the bars in the size and in the frequency, and then we measure the different amplitudes for each cycle per degree. We measure also the noise, calculate the signal noise ratio, and can then automatically calculate the visus from this patient. And this is a very nice description is in the paper from Professor Redder. Another objective tool is glaucoma screening, function tool. You have structure tools with the OCT, but sometimes OCT show good responses or good structure, but patient has also problem. And the combination function and structure give you a good tool for glaucoma screening. And this software is based on the paper from Professor Bach. And you have here, you can here, this is a flash VP, you have a pattern ERG, you have a pattern ERG with smaller check size and with larger check sizes like here. And if the response is in both check sizes perfect, then it's normal. Is in the large check sizes already is a response, in the smaller check sizes not, is early, and if both very low, then is advanced glaucoma. This is also very nice, the description in the paper from Professor Bach, and we use this in our software. The next tool is also you can use the objective visual field examination. We do this with a multifocal VP, with a 4-channel VP. Here you can see the stimulation. These are small checkerboards, multifocal checkerboards. And then you can see here the response from each area from the visual field. And you can compare this also with the visual field. And you get also a correlation and have an objective tool for visual field examination. And with the baby flash is a handheld system. Is the best for children. You can, if the child moves the head, you can also move with the device the head according where the child is looking. Here you have a button, you can start from here and you can stop, and you can also use the next step from the examination. You have different steps in the examination, and you can complete in the complete time, concentrate to the child. It's not necessary to put any mouse or keys on the keyboard. Here you can see again all our possibilities of the tests from the pattern, multifocal visual acuity, Ganzfeld, pupillometer for the children, and nystagmography. This test was all objective test. This is very nice for electrophysiology. You have objective test. One test is what we offer is a dark adaptation curve, but this test is an objective test. The patient see a little light, and if he can see, he push the button, and then we get during the 25 dark adaptation time, the dark adaptation curve. Here's the summary of all our functions. We deliver with all protocols according to the ISAP standard. We have normal values, but you can easily integrate. We measure automatic the pupil size. We have special target for the children. Optimize shorter protocols for tests with the children. It is also important to have a good impedance. After you put the electrodes on, you have to measure the impedance. We show in the impedance test also how to put the electrode. We have automatic artifact rejections in the protocol. If the patient makes some blinkings, then the curves automatically rejected. With digital filter, we can later on make the better signal processing. Offline averaging help also to get better results. And the typical curve, what you see, is also very nice tool. We can measure pattern VEP and pattern ERG in the same time. Then you can very easily find out, is the problem more retina or is the problem more from the visual cortex, optic nerve. With even and odd average help you to better see the reproducibility. Also fast Fourier transformation help you. It's not necessary to put markers. It's also for screening very useful. Then the eye fixation camera. You can also print all printouts as a PDF format. And we have objective visual acuity test, glaucoma test, advanced glaucoma follow-up, multifocal VEP. You can work in the clinic in the LAN, as you can have for different places the results. For scientific papers, you can export all data to Excel. You can also have DICOM interface and service via TViewer. So this was all the summary. And you know, for electrophysiology, it's necessary to know the basics, to know how to analyze. This was the talks before, and to have a perfect device. This is our work from Roland. We will deliver the perfect device according to your needs. And the consult is also, we help our customers to get good results with our training and service and after sales support. I want to say thank you very much.
Thank you, Mr. Finger. We are running very late now, so we'll take very few questions now. Rest of the questions we can answer through email. So I'd request Mrs. Kiran, just can we have some questions to answer now?
Gopal.
Yes, yes. I think Dr. Parveen Sen can answer few questions which are there for her, and she can go ahead, ma'am.
Yes, yes.
Some concern that probably the basics have not been touched very well. So of course, in trying to, show all things which electrophysiology could do for us, definitely I have not had the time to go into detail for a lot of things, but then probably we have to keep it for the next discussion. So the other things are that some basic things, that ERG changes are reversible on stopping the hydroxychloroquine medication or not. So it is, to some extent, these are permanent and not possible to reverse them unless you pick them up very early on. But a few changes are permanent, which is why it is important to do screening and to follow up these patients. And where all do we need a VEP test? In our clinic, we use it most for optic neuritis, especially in children, and who, as I said on presentation, can have a very poor vision, so the other tests cannot be done. Then in patients who are on ethambutol, we do VEP, who come with a sudden drop in vision. This is one of the diagnostic tests which can be done. Then there is a question on whether would you want to do ERG or VEP to assess DVM or CVI. So this would probably depend upon what you are looking at. So if you are looking at to record the vision of these children, I think sweep VEP would be one of the most useful tests which can be done. Maybe Dr. Farooq may want to add something to that. Your take on it, Dr. Farooq. What tests would you like to do for DVM or CVI in children?
I really have to read the question. Can you guys hear me?
Yes, sir.
Yeah. So
Which,
what test would you want to do in a child who comes to you with the CVI?
where is the question? Can we use ERG or VEP to assess? What's the CVI? I'm sorry, what is the abbreviation for?
So this is, I think, cerebral visual impairment. Children who come with cerebral visual impairment, would you?
Well, the problem is that the single channel that we use now is only up to the chiasm. Can we hear me?
Yes, sir.
Yes.
Yeah, okay. In order to test any visual pathway problems that it's post-chiasmal, you need to have multiple channels. You need to have 3 channels. This is what we do in albinism, for example. Also, cerebral palsy, patient would have cerebral ischemia. You need to have multiple channel. The reason is you get, for the single channel, you get one response, single response, which coming from the 2 eyes together. So it's very difficult to distinguish any focal depression in any of the hemispheres. So 3 channels testing is not a standardized test. So, but this is something could be available on the Roland system.
Yeah, so here we also, if we would want to check the vision of these patients, we have found sweep VP to be extremely useful because it's an objective type of testing. So just for a fraction of a time also, if the child is able to fixate on the screen, we can get some assessment, and that helps in uh, uh, their visual rehabilitation. So another question is, what are the points to be kept in mind to read an ERG report? So I think first is that it has to be recorded under ISEF criteria. So you have to make sure that you're following all the protocol which has been given. Then you have to have your own normative data so that you can compare it, because each machine will have its own data, and each machine will show different values. The electrode which you have used for the recording, that will show a different, each electrode will have a different response, or the waveform or the amplitude which is recorded. Once you have taken these things into consideration, then the next one that you need to do is that you see whether your divide your report into a scotopic and a photopic responses. So first, looking at scotopic, you keep in mind that you are now assessing the rod function. So when you look at the scotopic, you see whether in the first dim flash, whether normally also you will not see a um, waveform. So you will not see the A wave in that. That is because the flash is so dim that the A wave is not recordable. So that is not an abnormality to not see the A wave in the dim flash. Look for the B wave here. Once you see the B wave, you see whether it is normal in amplitude, what you normally see in your lab, or it is decreased. If it is decreased, you already have an indication that you are looking at a bipolar cell defect. Then you come to your bright flash. Again, if you see that here the A wave is normal, that means your photoreceptors are good. The ISEF has added the 10.0 flash, which is a high intensity flash also now, because that is particularly meant to see how well your photoreceptors are functioning. So if the high intensity flash also shows that the A wave is not as good as it should be, then definitely the defect you have to look at the rod responses, the photoreceptors. But if your other than the dim flash, if your 3.0 and your 10.0 flash, the bright flash, is showing you a good A wave, it means at least your rods are functioning well. Same way, look for A wave in the photopic responses. So if you have a good A wave in the photopic responses, now it means your cones are functioning well. So this is how you dissect it. You want to see the bipolars. Now you look into the B wave of the scotopic responses. So like this, you can dissect each and every bit and see the last is you can see the latency. Most of the diseases, the inherited retinal disorders that we are talking, are usually the ones which affect the amplitude. Some will affect the latency also, but largely it is the, because most of the inherited retinal diseases, they are causing increased apoptosis, increased cell death. So it is the number of cells which are going down. So as long as the number of cells are going down, it is the amplitude which is going to go down. If you look at the cell dysfunction, that the numbers are good but they're not functioning properly, then it is usually the latency or the implicit time which is prolonged. You would want to add anything to that, Dr. Farooq?
Can you hear me?
Yes.
Yeah, well, again, you have to also consider the age, the scope of the pathology that you're dealing with. It's very important before reading, looking at the waveform of any kind of electrophysiology, is to get an idea about what kind of a clinical presentation of this patient is. This is very important because in many situations you have similar presentations. And for example, if you're missing the B wave and maximal response, something we call electronegative responses, you can find this in multiple diseases. But if you have a good understanding of the history, the clinical presentation of the case, the age, the sex, all these things will help you to interpret the results more accurately. The other thing is, again, in children, you will never have a standardized figures or numbers that you will be just check and say, oh yeah, this is like that much. And you have to look at it globally. And the waveform configuration is very important in children. How the waveform is configured to take the proper components of each waveform. If the proper components are available, with a little bit of delay, then you can look at it also as something could be normal. It's unlikely to be normal in an adult where you have everything comes in the right time and in the right amplitude, and then you have something comes delayed. Yeah, always compare both eyes. This is very important. One of the eyes, usually hereditary disease, usually affecting the two eyes, but there are other conditions that you can have a unilateral kind of a pathology that then the other eye would act as your standard, especially in VEP and optic neuritis, optic nerve diseases. Yeah, that's it.
I think, and I would probably like to add refractive error also to it, because anything which is more than +6 or -6 diopter will again affect your amplitude of the responses. So that again you have to keep in mind. Sometimes high myopes, they may come with the history that of difficulty to light adaptation, and you get an ERG done and you see both the rods and cones are down and you feel, is it RP? So high myopes, because the refractive error itself is high, that itself can cause a decrease in the amplitudes of the ERG, even if you do it with the correction in place. So that can happen. So that is another thing which needs to be kept in mind. And of course, the maturation of the retina has to be kept in mind, because first 6 months it is really less, and it slowly takes some time before it comes back to normal. So I think there's another question was there on which is the best electrode for fulfilled DRG. So we personally here, we use the Birinelli electrode, which we are quite happy with, because it gives you a very stable configuration, with the reference electrode being the contact lens itself, which serves as the reference electrode. And because it is a contact lens electrode, the blink responses and all that are also much lesser. So that also does not cause too many artifacts. So it's a very stable configuration. The flip side is it's usually expensive and a little difficult to get. So you need to keep a stock of that, but it is reusable. It's not disposable. DTLs we have used, they also give a very good response. Especially for pattern ERG, you have to have a DTL electrode. You cannot do with the Barinellan electrode because it causes defocus of the pattern on the screen. So these are the two electrodes that we use. We have something, but the DTL is a disposable electrode. So, which is again, in Indian scenario, it's very difficult. So these days, because of this COVID infection, we have not been using the Barinellan electrode because it's a contact lens electrode. So skin electrodes is one thing, but for ERG, sometimes you can also have something called the DTL thread, which we use, which also gives you a good alternative and reduces the cost. Zari electrode has been used for with a similar way of using it. So these are whatever you use in your lab, you take a normative data for that and compare your normals and abnormals of with the reference of that electrodes. That is most vital.
Thank you, ma'am. We have more questions. First, we will answer all this over mail. We are running very late now. I would request our director, Mrs. Sena Samane, for vote of thanks.
Yeah, good evening, viewers, doctors, and the panel of speakers. I thank you very much on behalf of our company, Toshbro Medicals, for spending your precious time with us today. Dr. Sen, Dr. Mula, Mr. Pinger, thank you again for being with us and giving us so many insights on the subject. I'm very grateful to you. We hope to meet you personally soon, and maybe we'll be able to thank you in person someday very soon. For our viewers, just for information, we are running some lockdown specials. ERG from Roland is part of it. So if you are interested in some special information and some special pricing and some special terms, get in touch with any Toshbro person you know, or with me personally. My name is Shahnaz Tamane. I'm located at Bombay, and our addresses and phone numbers are very easily accessible. I thank you everybody again for this event and making it a success, and I bid you good evening. Thank you again. Bye.